So I'm delighted to introduce Dr. Anna Nordvig, who's a neurologist and researcher at Columbia University in New York and New York Presbyterian Hospital, and is funded by the National Institutes of Health in the States, and has been working on the cognitive syndromes of acute and long-term COVID. So Anna, very pleased that you're here. Looking forward to your talk. You've got 15 minutes and then we can have a few minutes for questions, leaving time for one more blitz talk at the end. Thank you.
Well, thank you, Dr. Zandi, for having me here. Indeed, it is really an honor to present my work. Can you see my screen?
Perfect, thanks.
Okay, so I'll tell you today about post-COVID-19 encephalopathy, and my talk will focus on some evidence for this as an emerging neuropsychiatric entity, and I'll also touch upon a potential link to neurodegeneration. Very quickly, early research questions evolved from respiratory to neurological involvement in COVID-19, and some of the work that we put out talked about possible links to neurodegeneration as well as prominent microglial nodules. We believe that there are many cognopsychiatric complications of COVID-19 because we actually also saw that there were at least rare reports of encephalopathy and other neurological outcomes in other coronaviruses. And of course, many reports of acute cognopsychiatric complications in COVID-19. But what we were hearing in clinic was something more. It was past the acute point. And these are direct quotes from many of our patients. The concerns were varied, and it made us think, this potential systemic inflammatory trigger of COVID-19 and as a proxy for other potential inflammatory triggers, could it be leading to microglial nodules and neuronophagia as one potential mechanism towards neurodegeneration by way of a permeable blood-brain barrier, maybe silent or the happy hypoxemia, hypoxic anoxic injury, or not so silent, the neurovascular bundle decoupling, periolfactory bulb or vagal inflammation, or neuroimmune activation. And why is some subset of the patients who had acute COVID developing post-COVID encephalopathy? Could there be host factors? Could there be a more permeable blood-brain barrier leading directly to this via potentially a systemic and then neuronal autoantibody recognition, and maybe regional differences in vascular injury, inflammation, brain mechanisms, or even altered neuron-glia communication? And in some, is post-COVID encephalopathy notable for being a risk factor, a biomarker like a stress test, or a trigger for neurodegeneration? And points to consider in that pathway are: is it an inflection point? Is there, and can we also look at the involvement of immunosenescence and inflammaging? So before we really started seeing these patients en masse, we decided we really needed to understand how did these symptoms resemble diseases we already knew? And so some of the research structure and the clinical workup actually stems from a lot of these other, and there are more entities that we've considered. And I have to, of course, give a shout out to Body Politic COVID-19, which did a massive survey of self-respondents highlighting the fact that there is cognitive dysfunction in over half of the participants responding. And there are many other smaller studies that kind of highlight this point. So we started our clinic. It's absolutely a convenience sample. It's an observational study. There is no control group yet. 50% are self-referred, and 50% were referred by another physician, either at Columbia or throughout New York City. Out of the patient referrals, we included the first 30 consecutive patients, and we've prioritized local patients. Very importantly, these are almost completely not ICU patients. So out of 30, we have one ICU patient. And that is done for a very specific reason, and that is to really focus on some of the mechanisms that exclude hypoxic and anoxic injury and complications of ICU stay. And the benefits of this approach, so we thought consistency of a deep clinical evaluation. We have some additional history from the family to really estimate at a baseline, even though in most cases we don't have a chart baseline. And really mainly for hypothesis generation, starting from the bottom up. In the future, of course, looking at control groups, blind interviews, and questionnaires and large cohort studies. So to summarize our data, out of our 30 fully characterized patients, not all were women. So I know there have been some reports focusing on women with post-COVID encephalopathy. 43% of our patients were men. The average age was kind of in the 50s. 30% of our cohort was 60 and older. 70% was Caucasian, very educated cohort, 16 years of formal schooling on average, and 73% working. Only a small amount that had benign forgetting that they reported, so a very cognitively healthy cohort to start. This is pre-COVID, pre-pandemic. And 17% actually, interestingly, had ADHD-like symptoms. A few even had diagnosed ADHD, but never needed medications to be very successful in work. And a total of 66% that actually had some underlying pre-pandemic mood symptoms or mood disorder, which is kind of an interesting finding in itself. This was a breakdown of the severity of our patients. So like I said, most were in the CDC classification of moderate, which is more strict than the WHO classification. So the moderate and mild patients never had to go to the hospital. And most of the severe only got nasal cannula. 67% after COVID, long after, continue to have difficulty working. 10% remain unable to work. Of course, 100% of our patients had brain fog, cognitive concerns, because we are a brain fog clinic. And 100% of the 5 patients that we had that had ADHD-like symptoms had their symptoms exacerbated, whether they realized initially or not. A pretty high average mini mental score, although in our older subgroup, the average was about 24. And again, very interestingly, an even higher percentage reporting new or worsened mood symptoms on top of the baseline, 53%. Can you see that? 53% worsened renewed, and 37% brand new cognitive symptoms, even 7% developed new suicidal ideation. Now, the recovery seems very varied, and up here you'll see, so this first group of patients, down here is the recovery time in days from onset. For the first 4 patients showed no improvement, and the average age really didn't differ so much across these groups. Then there was a large group that showed mild improvement, but were not able to function at their full baseline, many of them still disabled from work. Similarly, as many showed significant improvement, and we had one patient who kind of discharged himself from clinic and said, I fully recovered, but it took a while. The patients here that are in red, that have asterisks, are those who were hospitalized with severe COVID. One of them was an ICU patient, and like I said, except for the ICU patient, most of these only had nasal cannula. And again, the blue here is the time until they developed anosmia or ageusia. Not all did. And then this is the time until brain fog. The point here is that the brain fog developed fairly early, and most of the time patients only realized it as soon as they went back to their school or work. Of course, maybe if, realistically, the brain fog may have developed during the time of acute symptoms. Also, the end of the acute period was judged based on the self-report. We didn't have PCR tests to prove that the acute infection was over. We believe that we need a definition for post-COVID encephalopathy. And the definition we've come up with is it's a subset of long COVID, or PACS, with significant cognitive impairment. And you have to have recovery from acute infection, however that's judged. You have to have post-infectious cognitive symptoms, and it still is a diagnosis of exclusion, so it's not otherwise fully explained. All of the other long COVID PACS symptoms can be supportive, but are not required for the definition. And I'd like to propose some phenotypes that can help with the clinical framework and also for the research phenotyping framework, and they are AEIOU. So these are to characterize the complaints that the patients have and how we kind of categorize these patients in clinic. A being amnestic in language, E being executive, but also incorporating inattention, both leading to trouble learning. I being inflection point of neurodegenerative disease that may have been underlying or accelerated cognitive aging. They're a catch-all for mainly apraxia, some bradyphrenia, some visuospatial construction deficits. And then U being an unmasking or worsening of other, non-dementia, but other pre-existing cognopsychiatric subclinical syndromes like unmasking of ADHD or even one case of epilepsy. In terms of what percentage of our patients had the cognitive complaints in this phenotyping, many had amnestic and then executive inattention. Fewer had the other, we had quite a bit of both inflection and unmasking. When we did a quick heat map, we could see that there was a lot of overlap in reporting of amnestic and executive inattentive symptoms, which is interesting. When patients said they have memory problems, sometimes it was more of an executive profile, but the complaints were often both. And there were other, I call them neurological because they could be, neurological changes reported. Interestingly, as I mentioned before, mood and behavior being the most commonly reported across the entire spectrum, and orthostasis or thermodysregulation being very close second, fatigue, and then sleep and headache, disequilibrium, GU symptoms, hormonal libido, and many of these had fluctuating symptoms, few days on, few days off, few weeks on and off. There were other reported symptoms as well, which are important to note, and 33% tried alcohol in a social context, and out of those, 2/3 worsened for weeks. So that's something to take note of. Those with a possible neurodegenerative inflection, actually when we categorize by the AEIOU phenotyping, those in the inflection category, interestingly seem to report fewer symptoms. Could that be because these are older patients and that it's just a different reporting style, or truly did they actually have fewer amnestic and executive symptoms and had less of a fluctuating course, which is kind of just an interesting finding here. In terms of our workup, so we think it should be very tailored for each patient, but this is kind of the menu that we would draw from. And looking at some of the specifics of this, the neuropsychological testing, I'd like to thank Dr. Stephanie Assuris for her help here. We've managed to do neuropsych testing on some of our patients and are slowly working through them. And we noticed that for the patients that were about 60 and under, the average age was 50, there were few objective deficits. Could this mean that for this highly functioning, very highly educated group, the tests are just not picking up their deficits? But really it was just executive domain where they had relative weaknesses, whereas our older patients were more impaired across the board. And in terms of some of the other clinical things that we do that contribute to our research, so in this one patient with rheumatologic disease, new attentional, fatigue, depression, headache, and insomnia problems, we found what looked like an orthostasis, certainly with a lot of symptoms. One of our patients even reported breaking her nose falling from an orthostatic episode, standing up after being in bed for a while. So we have many of these types of tests. We also are concerned that we might be missing something because premorbid scans might really be unchanged. So while we're seeing some white matter hyperintensities, we're seeing some level of mild atrophy, we feel like perhaps some of this was there. So this is a patient where she had pretty significant kind of speech apraxia, and she had nearly identical scans pre and post-COVID, and she continues to have long COVID symptoms. But so some more to do on that front. But we have seen some unusual findings. So on average, Fazekas scale about 1 to 2, but number of white matter flare hyperintensities in patients who really had no reason to have them, no prior headaches, no prior infectious diseases or rheumatological issues. We're looking at arterial spin labeling, one of the MRI sequences that's a useful sequence for hypoperfusion in a different patient, and in about half of the 6 that we've done, we've seen some regional hypoperfusion deficits here in the anterior temporal lobe on the left, maybe a little bit inferior frontal gyrus. And we're also using other modalities when needed, like for a more formal measure of perfusion inspect. This other patient, even younger patient, had a pretty normal MRI, a perfusion deficit left posterior frontal and parietal and temporal lobes, and then on the SPECT had pretty diffuse patchy hypoperfusion. If neurodegeneration is suspected, you're looking at the MRI. If you're seeing deficits, maybe a PET might also be useful. Here we noticed the patient that had some asymmetric atrophy and ventricular vacuodilatation, and on the FDG PET noticed a kind of atypical hypometabolism diffusely, including the basal ganglia. DAT scan as well being a useful marker. We had an older gentleman who had mildly slowed gait and intermittent benign memory lapses at baseline, but was still fully functional in his life, retired, playing golf daily, had a course of COVID where he needed nasal cannula and immediately started moving slower, had fatigue, congestion, and then marked deterioration. He developed severe persistent bradykinesia, micrographia, bradyphrenia, and all these other symptoms, but interestingly, no tremor and totally normal constructions. See some parietal and maybe some occipital atrophy, but a floridly positive DAT scan here. We're also looking at CSF, obviously harder to convince patients to do, but these are some of the other studies that have been published in acute COVID, and then also in patients who had cancer 57 days after acute COVID, showing that single cell sequencing, flow, cytokines, and immune markers, can be studied, but these are not so clinically available. So we do get CSF when we can, when there are red flags. And so far we've seen 2 cases with abnormally low amyloid beta 42, but normal p-tau and total tau in the CSF, so kind of abnormal for Alzheimer's, for example. And 1 patient with elevated protein that was actually found to probably have an unmasked nocturnal seizures going to full-blown temporal lobe epilepsy. So our takeaways are not all post-COVID encephalopathy is created equal, that it is worthwhile to phenotype cognitive symptoms and also other neuropsychiatric long COVID symptoms that seem to have a high concordance with the cognitive symptoms. And those might reveal homogeneous clinical groups for our studies. Also, a question arose, why do so many mood symptoms and executive attention deficits coexist? Could there be a prefrontal cortex deregulation of the limbic system? And also looking at neurological red flags that maybe suggest an inflection point or unmasking, these being some of the red flags that we came across that might prompt a visit with the cognitive neurology or memory disorders group in your center. Of course, leading to work that has to be done with large cohort synchronization, developing homogeneous questionnaires. This is C4R, something where we have where Dr. Mitch Alkind from Columbia is spearheading the neurology portion of this, developing homogeneous questionnaires across 14 cohorts, 50,000 patients, also developing something similar for NAP with Dr. James Noble, the co-leader for this particular effort. And in terms of treatment strategies, so of course that's what we're all asking. These phenotypes are helpful, as are some of the underlying additional long COVID symptoms. And these are some of the treatments that we have used. Sometimes observation is the way, but other times we go with a medication that might address several of the symptoms. And of course, thinking about clinical trial targets. So with that, I'd like to give my deep gratitude to my patients, to the guarantors of BRAIN and the conference organizers and their tech skills, and to all of these thoughtful people, in particular, my mentor, Jamie Noble, for 11 years now. And I'd just like to highlight a quote here from my very first post-COVID encephalopathy patient who said, "It goes for where you're weakest and what you care about most." And it couldn't be more true. So we will continue our work for all of you. Thank you.
Thanks so much. Really great talk, Anna, and done from New York and from that time when New York was particularly badly hit. And a lot of work done there by clinicians looking after patients. So we've got to move on very quickly, but time for 1 or 2 questions. A couple of questions came up, one from Masood Hussain and another from Angela, which I'll combine. Did you see any, obviously getting some good control groups and disentangling many of the things you've seen is what's needed. But did you see any relationship between your specific tests in cognitive impairment and mood? And I'd extend that and say, how can you distinguish amnestic features in someone who has attentional problems as well? And also, did you see ethnic differences? In fact, did you see a good ethnic representation in the people self-referring to you? Or, for example, it's possible to say that often those people in most need are not getting access.
Yeah, and that's it's excellent questions, and it really is problematic for us because the word spreads over the internet, it seems, and we're just not getting to the areas. So we're trying to self-refer from the other clinics that have more ethnic diversity. So many of our patients come from the Dominican population locally that suffered acute COVID in the hospital, but as you saw, 70% of our clinic patients are Caucasian. So I don't think that our cohort, given that it's a self-referred cohort, can speak to the ethnic diversity of long COVID and of post-COVID encephalopathy. But of course, symptom reporting is absolutely going to be different. In terms of the concordance of cognitive, let's say like attentional and mood deficits, indeed, that's kind of why we wanted to show that even within like the A and the E groups, the amnestic language and the executive and attentive groups, we saw a preponderance of mood symptoms. And it was just interesting to us that even pre-COVID, pre-pandemic, there was such a high prevalence of mood disorder. But it is important to note that, of course, depression and anxiety can manifest with what used to be called the pseudodementia, but can absolutely have attentional and executive deficits, and those come through on the neuropsychological testing, and that can be used to guide treatment.
Okay, perfect. Thanks so much. Thank you again.